Good morning. How are you?
Very good. We are very pleased that you are with us today. And thank you for participating in this very important symposium. And I would like to request that before you start your presentation, that you give a little introduction to yourself.
Okay. Good morning, everyone. I'm Gary Puckrin. I'm president of the National Minority Quality Forum. We are a research and education organization based here in Washington, D.C. Our work, we have focused on collecting health data now for about 20 years. We have a database of over 5 billion patient records. We collect data on about 160 million lives per year, covering well over 100,000 different conditions. Today, I'm going to be talking to you about the work that we do in cancer and the intersection, really, between environmental justice and cancer. What I always like to confess at the beginning of my talk is that my doctorate's actually in history. I'm not a clinician, but we do a lot of work in the medical space. So the story actually begins when the president was vice president and launched the first cancer moonshot. And we were a part of that cancer moonshot. We used our data to map 5 cancers by zip code. Colorectal cancer, prostate cancer, lung cancer were the main ones that we did. Breast cancer were the main ones that we did. And it was interesting. We could see that cancer varied by geography across the country, meaning the prevalence of the cancer was very, very different across the country, and no explanation for it. But in our data, we could tell not only where cancer was presenting, but we know who was treating them, what are they treating them with, what were their outcomes, et cetera, et cetera. When the president launched the renewed cancer moonshot, we again signed up for that and started to look. We have 100% of the Medicare and Medicaid data, so we're able to go in and begin to take a look at how cancer, and this goes beyond the 5 cancers, now we're talking about all cancers, and try to understand how that was working. The vice president was in Flint, Michigan, and she promised the folks in Flint that she would help out, that they were still suffering from the effects of the water toxins and were looking for help. And so they followed up and approached the vice president about doing work on a cancer cluster. They thought that they had a cancer cluster as a result of the water crisis. The vice president sent them over to the White House because she didn't think that she could help them immediately get funds to study the cancer cluster. And the White House reached out to us and asked us if we could help the folks in Flint, which we did. We started off by doing a listening session. We did several listening sessions in the community to try to understand what was going on, how people felt, what did they need, and how we could be helpful, which led to a health fair in which we brought in some industry partners, EPA, the White House presented to learn a little bit more about cancer in Flint, Michigan. April is National Minority Health Month, and our organization helped to start uh, uh, National Minority Health Month through an act of Congress, I believe in about 2003. Congress recognized April as National Minority Health Month. So we went back to the White House and said, we'd like to do a listening session for the White House to talk about, introduce them to some of the issues that minority populations were experiencing um, uh, related to cancer. We didn't feel as if they had gotten sufficient information from the community itself. We wanted to bring in community voices and let them talk about cancer in their community. And so, they agreed, and we organized a listening session, and we brought in not just folks from Flint, but patient advocacy groups, Hispanic, Native American, Asian American, industry partners, to provide the White House with a listening session. Fortunately, my staff was also smart enough to invite EPA in because we had not done a lot of work in the environmental justice space, and because of Flint, we thought that would be a good voice to have. We also had CDC and NIH there as well. And the presentation from CDC, from EPA, was really a eye opener for us. I know for folks in the environmental justice space, it probably wasn't a unique story, but for us it was. We operate in a completely different space. And so what EPA said to us was that somewhere around 59% of the people who live in a carcinogenic environment are minorities. And that was really striking to us because a lot of our work has centered around looking at medical care. So I would describe it to you as we look at uh, medical injustices in minority communities, and so hearing about environmental issues was completely new for us. But what we realized as we listened deeply and went back and did our homework and research and got a better understanding of the environmental justice movement, etc., is that the medically underserved communities and the environmental justice communities were in fact the same communities. Say it to you another way. The communities where we're seeing uh, exposure to carcinogens are also the same communities where we see medically underserved communities. And that linkage was incredibly important for us. And the reason why it was important is because the um, communities that were being exposed to environmental toxins were being exposed to those toxins because of public policy. That public policy had allowed um, those communities to have excessive risks for carcinogens. As you know, dating all the way back to the work of Ben Chavis and others, and the work there continues. But what we were able to add to the story is that these communities were also medically underserved, and they too were medically underserved because of public policy. That when you looked at these communities, they have somewhere around 50% of the residents, maybe slightly higher depending on the community, get their health care through Medicare and Medicaid, through public health insurance. And public health insurance um, essentially apportions the care. I'm not going to use the word rationing, I'm going to use the word apportion. And as we began to scratch deeper into this, what we came to understand is that there's a general sense in the health economic community that we have a unlimited demand for healthcare, unlimited demand for healthcare, and a limited ability to supply that healthcare. And so, because demand was outrunning supply, it would necessarily contribute to inflation because prices would get set to meet the demand. But also, even with the higher prices, that supply could not meet the demand. And so there was a presidential commission set up under Jimmy Carter in 1983. I encourage you to go read it. It's called Securing Access, a presidential commission of 1983. And it talks about the need to provide what they call adequate care. Adequate care being care that was less than the care that was needed, meaning the care that um, the patient actually needed to be healthy, to survive, to take care of the disease that they were confronted with. But that it was appropriate to provide adequate care, which is less than care. Now, the commission goes on to talk about no community should have excessive burden, but never gets around to establishing metrics and how do you determine that, et cetera, et cetera. So the point I'm making to you is that uh, within healthcare, there is this idea of apportionment of care. Um, and what the commission also said is that folks who could afford to buy additional care, I mean, outside the system, buy it on their own, should be allowed to do so. They should be allowed to pay for the care that they needed and not feel as if there was a moral obligation, either by the government or by those who had the financial means to buy the care, that they were somehow uh, morally obligated to do more for those who could not. And so there was no moral risk. There was no commitment to provide uh, best care to everyone. And so what you end up with, obviously, is a tiered healthcare system. And what we came to appreciate because of the work of the social justice movement is that that care, um, less than it's called beneficial care, the care that you actually need. Uh, so beneficial care was not being provisioned in those communities, but adequate care was. And so we stepped back and began talking about and labeling it medically underserved cancer care community. That around the nation, there are these communities that are medically underserved for cancer care, and in many instances, these are the same communities that the environmental justice community is talking about in terms of cleanup, reducing those carcinogens. The problem is that on the medical side of the ledger, there is no national medical justice movement in cancer care to address that problem, right? And so, um, 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 while the environmental justice movement is at least bringing attention to the issue, when it comes to cancer care in those communities, um, we are not necessarily making the investment or have organized a program to address the internal needs of those communities. Now, when I speak about public policy, I'm not just speaking about government, right? I think one of the things that we don't own enough that is really unique about democracy, particularly our democracy, is that we are at once both the governed and the governors. Through our vote, we are governors. Now, that particular vote, gets divided up, a couple of 100 million people, but each one, each one who casts their vote, um, decides public policy. The elected officials are really a proxy for what we, the people, decide. That's importantly important to remember because sometimes um, we think that the obligation just lies with government. And so when we talk about public policy, we are talking about all of us. We all are doing this. We all have decided through our proxies, those in government, that we ought to have some people living in carcinogenic environments that we know are dangerous to them. And we also say that we're not going to deliver best scientific care to those who we've exposed to carcinogens. So I've talked to you a little bit about cancer care, but let's take a little bit deeper dive into exactly what do I mean by medically underserved cancer care. So first of all, and when you begin to go into the data, if you remember, we have the data, so we can go into the data and take a look. What you're going to find is that these populations are not being screened to guidelines. They're not getting the mammogram, the PSA tests, the colorectal screening, the lung cancer tests, etc. Right? So the routine screenings are not occurring. And some of the reasons why those routine screenings are occurring is because of public policy. Maybe they're uninsured. Maybe the plan that they're in restricts access to the screenings because they set the guidelines so that populations that have a unique risk of getting screened later than they should. Maybe they haven't done the real work of educating the community, particularly about their unique risk and the reason why they have to be more vigilant in managing their cancer by getting screening. Now, the challenge is there are probably 100 different cancers. We only have screenings right now for 5 of them. And so there's a broad gap. But even inside that broad gap, those 5 screenings, what we see is that these populations are underserved. Because they're not getting screened appropriately and early enough, they're also getting diagnosed for cancer late, meaning the cancer is being diagnosed when they are symptomatic. And oftentimes, when they're symptomatic, is because the cancer has metastasized. It is no longer local to one organ in the body, but it has now spread out to other organs in the body, and that's what we mean by metastasized. It's non-local now; it's all over the body. And when cancer metastasizes, we really do not have good science to intervene because it's spread to all corners of the body, and it's not manageable. So when you go to look at the data, what you see is that in these underserved communities, they're more likely to get diagnosed at stage 3 and 4 cancer. That's when the cancer has metastasized, is no longer local, it's spread throughout the body, as opposed to stage 1 and 2, where the cancer is local and we have better ways of managing that cancer than we currently do. And so, because that cancer has metastasized and they haven't gotten diagnosed late for cancer, what it translates into is poor survival rates. The cancer is essentially untreatable, or we have limited treatment, is probably a better way to put it. And when you compare survival rates, the survival rates are low. So let's review now. So we're talking about communities that are being exposed to carcinogens that we underscreen for the cancer risk that they have. That means that their cancer gets diagnosed late, which translates into poor survival rates, comparatively poor survival rates. Right? So, but then there's also the added burden that we don't do clinical trials in these communities. And clinical trials are used to better learn and manage cancer. It's where some of the cutting edge cancer care is available. And so the clinician who is treating these patients do not have the benefit of clinical trial to recommend the patient into when potentially therapeutic options have proved unsuccessful, and the clinician can then recommend the patient into a clinical trial potentially, where they may find a better option for the patient. So when you look at these environments, again, higher carcinogens, you're also going to find the absence of clinical research being done on the populations that are uniquely at risk because of their, not just their living space, but their working space as well. I should have made a point of that we're not just talking about living space, we're also talking about working space. And I'm sure you guys know from the data that workspace can also contribute to exposure. All right, so here we are. Now we have these communities, but the science is changing. Perhaps one of the most important changes that are underway in cancer care is diagnostics for cancer. So what we've learned is that cancer cells shed DNA into the bloodstream. And so what is coming available, it's actually, some of them are actually on the market today, they're called multi-cancer early detection screening. multi-cancer early detection screenings, which we call MCITs, multi-cancer early detection screenings, MCITs. Generally speaking, they can detect up to 50 cancers at one time from one single blood draw. So you go to the doctor and he draws your blood, um, and um, and the screening would allow for us to diagnose you with cancer for 50 different types of cancer. Now, remember, there's 100 cancers, so we're not necessarily finding all of them, but nonetheless, we're going from 5 to 50 with one blood draw. But what's also important is that they can detect cancer at very early stages, stage 1 and 2, when the cancer is just begins shedding in the blood, and have not metastasized. Those tests are available right now. Affluent people are getting them. They cost $1,000 a pop, basically. And if you got $1,000 every year, you can go get yourself tested for one of these MSITs and manage your care. They're also using the same technology, if you will, to understand if you have cancer, whether the medication you're using has got you in remission, and they can follow you through these tests to make sure that the cancer stays in remission. So there's a lot of other options there with these MSITs. But what's also important here is that the federal government right now in the Medicare and Medicaid program does not reimburse for these MSITs. In fact, the jibber jabber in DC is that the federal government is not likely to pay for these MSITs until about 2045. Take you into a deeper analysis of it, but suffice to say. Now, I want to be clear here. These MSIDs are still experimental. None of them have cleared FDA. There's also false positive results. So you could get a signal that you have a cancer, which could lead to some expensive workup, PET scans, etc., that are expensive, only to find out that the MSID was giving you a false read. And by the way, the MSIDs don't just say you might have a cancer, but they also localize it. They can tell you what organ in the body is likely to be cancerous. And so you can go get a workup, and obviously that's expensive and concerning because these workups are not inexpensive. And also, there's all of the anxiety that one must feel if you get a report back that, oh, we think you have a cancer, and you go get the workup, and come to find out that you don't. And so you've been put through all of that stress, in your family, etc., have been put through all of that stress. And so there's some concerns about using these evidences because they're not perfect. They have, so I don't want to exaggerate the number of false positives, but they are real, depending on the particular test that you take. I've been talking to you about DNA in the blood, but there are other MSIDs that look at blood plasma. So there are a range of MSIDs out there that are being developed. I think there are probably over about 40 companies. The reason why I'm talking to you about the MSIDs is because NMQF, my organization, thinks that those MSIDs can be used for surveillance purposes, right? So let's go back to our cancer communities where folks are being, we believe, exposed to carcinogens. We think they're rates of cancer may be elevated uh, as a consequence. So, it has to be said that there's no one-to-one correlation between being exposed to a carcinogen and actually getting cancer. But the suspicion is that there's an elevated risk there. And so the people who live in those communities are afraid that they live in a cancer cluster, but even more important, or just as important, that the cancers that seem to appear in these communities seem to be more aggressive. That from diagnosis to mortality seems to be a shorter clock, and some of that may be the consequence of the coming late into care and the cancer has metastasized. Um, right now, as I mentioned, we only have 5 FDA-approved screenings for cancer. Not all of them are portable in the sense that you can bring them into the community, and even where um, uh, they are available to be brought into the community, a mammography machine, for example, could be put into a vehicle, a van, and brought to communities for tests. But more likely, the person has to leave community. But even when they do, they're only getting tested for one cancer at a time, and they don't have the ability to diagnose multiple cancers. And so trying to use these traditional cancer screening as surveillance tools for populations that are at risk seems to us to be not the ideal uh, uh, device to be using. I don't know if you remember, I guess it was a train exposure in North Carolina, and there's some fear of environmental toxins having been spilled in the community. Our sense is you can go into those communities as a clinical research study because they're not FDA approved. But we can do data gathering in those communities by using the MSIDs and see if, in fact, you baseline them now and see if over time do they show some elevated risk for cancer. Uh, and, um, and that's what we're doing. Um, we are working towards putting together a study that starts off with using the MSIDs to see if, in fact, these communities where we know environmental toxins have been released, whether the MSIDs will help us diagnose patients and hopefully at an early stage of cancer so that we can improve their outcome. And so um, what we're working on is identifying 10 sites around the country. We want to work with those in the environmental justice movement to help us identify those sites, and we're putting together a meeting in March to bring together the medical community, the environmental community, and I'm going to talk to you a little bit about the payer community in just a second, because we want to bring them into the conversation as well. And what we also want to do is, um, if we find someone who has a signal for cancer, is not only get them through a confirmatory study to see if in fact they have uh, truly have cancer or not, but also to get them into best modern therapy. So one of the new therapies that are being used to great success is immune therapy. Immune therapy is essentially um, uh, enhancing the immune system in your body to um, attack and um, um, uh, hopefully suppress the cancer that is in the body, right? Those immune therapies are state of the art technology. They're not being used in these communities. You can go to Mass General and MD Anderson, and you can get those therapies. But when you look at Medicare and Medicaid beneficiaries, they're less likely to have access to these immune therapies. This goes back to we're not giving them beneficial care, we're giving them adequate care, and these immune therapies are beneficial care. And so what we want to do is to, uh, in the study that we're doing, um, have them have access to best modern therapy as defined by their clinician. What the doctor thinks will actually be the best therapeutic for the patient. Now, if you remember at the top of this discussion, I said to you one of the reasons why we have the medically underserved cancer care community is because of the idea that we can't provide beneficial care to everyone, care that they need. We can give them adequate care, but we can't give them beneficial care. And that is a hypothesis, if you will, of health economists. There is no study that documents that. You're not going to go into the literature and find a study that says we need to set up these underserved communities around the country for the poor and minority because we can't pay for their care. And so we can just give them, we can triage them to advocates. So what we've been doing is going to payers and saying, we need you at the table. That if we're ever going to do anything about health equity, particularly in cancer care, then you have to be at the table because we actually need to understand what does beneficial care actually cost. From doing the MSID surveillance all the way through to best modern therapy and hopefully putting the cancer into remission. And if we're really lucky, cure, what does that cost? How much is that? Because what we want to get to is a scalable model. We want a scalable model that says we don't have to have these underserved cancer communities around the country because we have the ability to pay for them. And so the idea is to co-create good science, clinical science, economic science, if economics is actually science, to document that we can do this. We, the public, this goes back to my point of view, which is we are publicly responsible to each other. That is what our social contract says, that every life is equal. In fact, when Jefferson wrote in the Declaration of Independence, he talked about the preservation of life in the first draft. It got reduced to life. But it is our obligation to each other. And so what that requires, of course, is that we do the science. We do our homework and not shortcut it, but actually put all this together. And we're putting this together in a way that others can take up the study and replicate it in other communities or make adjustments to it because it's learning. What we're doing is essentially what happened with COVID. If you remember, when we first were struck by COVID pandemic, we did not have testing for COVID. What we had was emergency authorization for COVID testing. And so we allowed to be used testing for the virus, some of which were not effective. And by follow up, we were able to say that this particular test did not work as well as that particular test. And what we wanted to do was to choose the tests that were most effective. And that's essentially what we're saying here with the MSIDs, that we're going to fly the plane, we're going to start flying them and using it. And over time, with good science and research, we'll find out which ones are more effective than others. And those are the ones that will survive. And those are the ones that we will continue to use. Because what we can't do is allow the people in these communities that we have put in this situation, that we, the public, have put into this situation, to go undiagnosed and untreated any longer. There is a sense of urgency about this that we must have, because lives are getting cut short. If you go into these communities as we have, and you hear the pain of people who have lost loved ones, children, parents, neighbors, friends, from these cancers, you understand that time is not a friend here. It is the enemy. And so we, the collective we, have a responsibility to them. That's what the American experiment is all about. That we're bound to each other. And we ought not to pick winners and losers by ignoring those who need our help. And so that is why we are committed to begin the process with the MSIDs and hopefully contribute to the development of that science in underserved communities. The affluent community is already getting it. They're already going to their doctor. They're getting the blood test. It's the people who can't pay out of pocket who have it. And when we're in community, what we find is people, when we talk to them about screening, they say, well, I don't really want to know because if I got cancer, I can't afford to take care of it. I'm going to lose time at work. I can't, my family can't pay for it. So the example I would give you is in the Medicare program. Immune therapy could be $100,000 or $200,000 or even more, depending on the size of the prevalent population, the number of people who need it, because the companies are pricing it based on the volume of people who will need their medicine. That's how they stay in business. They got to look at the volume. And in the Medicare program, Part B and D, and some of these are injectable, so they'll be in Part B. You could have a 30% copay. Think about that, 30% copay. That's why the doctor is not even talking to you about it, because 30% of $200 or $300 or even $100,000 is a lot of money, particularly in these households. In Flint, Michigan, for example, It's one of the poorest communities in the United States. Household income is about $25,000. How do you do a copay or co-insurance on those dollars? Of course you can't. And so it goes back to the setup of public policy that has set this up, because um, we've decided that the way in which we want to provision care is to give adequate care to some and allow others to buy their way forward. So um, um, if we're going to eliminate health disparities, and cancer care is one of them that we're taking on, obviously the question could be raised about diabetes and cardiovascular disease, because the same thing is going on. It's the same community, to be candid with you, but we're limiting our perspective here to cancer care. We want to go into those communities, African American, Native American, white communities, poor white communities, Hispanic communities, Asian communities. Um, uh, Race and ethnicity does not buy you out of this, all right? But I would also make the case for my affluent friends that it is hard for us to build a healthcare system where, um, because we shrink the number of people who have access to the therapies because of the way we have provision, it's hard for us to accelerate the science. And so you're really not getting the best that we have to offer, right? You may think it is. You may, leave your doctor's office feeling as if you got something that the rest couldn't afford to get, and somehow you're unique, but you're not. False premise. You're not. You're just not getting it. The system can perform a lot better for you if we're all engaged in the system. So I want to go back now to where we started, the war on cancer, which is what um, Biden talked about, but actually was also started by President Nixon in the 1970s. So I would argue that the science is bringing us close to the place where we can begin to write the last chapter on the war on cancer. We're getting that damn smart. We have that capability. In fact, I would argue if we expedited and made the investment in cancer care like we did with COVID, I would make the case over the next 5-10 years, we would bring cancer to a chronic disease. I think we have that capability between diagnosis and treatment. Major investments made. We could do that, right? But in order to do that, in order to make that possible, we have to be able to bring that science into every American community. Can't leave anybody out in that war. So the war on cancer presumes that at some moment we can bring best modern therapy, devices, medical interventions, screenings, whatever, into these communities that right now are underserved. And so, use sort of a military mind here, we're going into the stronghold of the worst of the worst, where people are being exposed to carcinogens, they're not getting the care, they're getting not screened, they're getting diagnosed late, their survival rates are poor, we're not getting clinical research in those communities. Those are precisely the communities where we need to be in and invest. Precisely the ones that we have to go to. Obviously, the great work that lots of you are doing on environmental justice contributes to that, and I think that's really the great thing that we have. All right, I suspect that I've said enough, huh?
Dr. Puckrin, thank you very much for your extremely informative, interesting, important, and passionate presentation. I personally did not know much about your organization before your presentation, and so I'm sure a number of people who are watching would like to know how they get more information about the work that you're doing and how they might be able to participate in the work that you are doing.
So if they come to our website, nmqf.org, nmqf.org, there are links there, and they can reach out to us, and certainly they can reach out to me. It's gpuckrin@nmqf.org. That's my email address, and I'm happy to connect you with folks on our staff who love the partnership because there is no separation between the environmental justice movement and the medical injustice movement. We're talking about the same thing.
And brings up my next question, which is, how can the participants in this symposium know where the cancer clusters are that you referred to, and whether they are living in those areas?
So we have our own geographical information system. We are hard at work at that now. And so give us a couple of months here, and we will have those locations mapped for you. In fact, part of the conversation I'm having with your organization is how do we bring all of this together? Because you've got data too. And so what we're saying is let's bring the environmental justice data and the medical data together, and let's identify these communities that are at risk for carcinogens at the same time are medically underserved. Those are our target communities that we have to do work in.
Yeah, that's very exciting, and I certainly want you to know that the Center for Engagement and Environmental Injustice and Health at UMD is very excited about getting that information from your organization and participating in the work that you're doing. Your presentation was very eye-opening, I believe, and on a personal level, my extended family and my own nuclear family has been pretty devastated by cancer, as so many families have. And you did mention the diagnostic screening that's available. And I just had my physical exam, and my physician didn't ask anything about cancer as part of my family history, or whether I would even consider spending $1,000 to get a screening that you referred to. Could you comment on that?
Yeah, two things. One is it's called Gallery. The company is Grail. Grail. They have a test called Gallery, and you can just Google Grail and it'll come up. Your doctor can order the test. It is $1,000, but it's like when we had the flat screen TV first came out, they were like $25,000. That's what's happening now. The price will come down, but if you've got some unique risks for cancer, it's a worthwhile thing to do for sure. I also want to say we're putting together a colloquium, and we're going to invite your organization to be at the table with us as we start to identify these communities around the country where we see the combination of environmental justice and medically underserved. So we're hopeful to build a deep collaboration with you as we do this. In a publishable paper we want to do, and a lot of research work that has to go on here.
Well, all of this is very exciting. I did want to mention something to you. I lived in Texas for 30 years, and I'm sure you've heard about Cancer Alley,
Yes.
um, and the and you also mentioned MD Anderson in your um, presentation. Uh, the the healthcare industry in Texas is heavily dependent on contributions from the fossil fuel industry, and um, I have heard that the healthcare industry is very hesitant to say anything about the link between fossil fuel extraction and cancer. And you were talking about public policy and the EPA. Could you just say a couple of things about that?
So, at the end of the day, it's really what you value, right? And my organization, we think human life is so precious and so unique and so rare. It's the rarest of the rarest, right? I mean, if you step back and look at the universe, ask any astrophysicist, and what they'll tell you is that we are rare, if not unique. And our attitude towards that uniqueness has to be re-examined. It's a difficult conversation because it's talking about how we value things and how we take care of each other. And there's some who like the old order, but the old order is dead. I mean, it's dying a miserable, slow, long. But we're headed into the future. In that future, we control health outcomes. We have the ability to do that. That's what the science says, that we can do that. So um, the skirmishes will go on in a lot of industries because the fact of the matter is, um, the way I would describe it to you is the economy has to support our biology. It's not our biology to support the economy. And so we have to align with what supports our biology. That is probably the most critical transitional point that faces us right now. It's a very hard and going to be a long struggle, but I can't see any future but that. And so at least that's how NMQF looks at the matter in the work that we do.
Well, I would like to thank you very much for agreeing to participate today. Your participation has been enlightening, and personally, I think the work that you're doing is very innovative and very important and very in line with the work that Dr. Wilson and the Center for Community Engagement, Environmental Justice, and Health are doing. And I hope that, well, I know that there will be many opportunities to collaborate with your organization. I was especially interested to hear about um, the lack of clinical trials in communities where the majority are people of color. I lived in the Rio Grande Valley for 30 years, which is 90% Mexican, Mexican American, Hispanic, Latinx, whatever is politically correct these days. And I know that the researchers at the University of Texas often had to put asterisks next to their research that said, you know, it's difficult to get people of color to participate in clinical research trials because of their experience in the past.
Yeah.
Their historical experience has not been great.
Yeah, that is absolutely true. And that's why we take so much time to go into community and listen. We do not do anything in the community before we listen and understand what the community is feeling. And sometimes the relationship between the communities and those who provide medical services for them are so deeply strained that they have to be repaired. But you can only do that by spending the time to listen and hear what people actually feel.
Well, again, thank you for your time today. And again, thank you for your passion. Thank you for your vision. And um, please know that you will have a strong collaborator at the University of Maryland.
Great. Appreciate it. And thank you for the invite. And have a great day.
Okay, you
All right.
too.
Thanks. Bye-bye.
Thank you very much. Ta-da.
All good. Awesome. So you'll need to do nothing on your side no more. Close it out. Cool. All right. Yeah. Do you have another one?